Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether I'm audible and visible, everyone. All right. So here we are to discuss the most important topics that are required for your upcoming FMG exam, and this is extremely useful for the upcoming be it the UPSC CMS exam or the NEET PG exam as well, right? So these are the must-know topics from medicine, few from pathology, right? Few from microbiology. So we have combined all of them. Is the audio visual all good, everyone? Thank you so much everyone for all the love. Audio visual is good. Is there any video lag or anything that you are seeing? No, right? So, yes, everybody here. So, this is where we can stay connected on the various platforms, and also the Medsynapse app, which is now the Speed Medsynapse app, the new app that we have, the Speed Medsynapse app, right? A new app with a much better interface that we have. So, we have all the short recorded classes also available there, and we have almost now ongoing the MCQ marathon online live classes going on every day 11 a.m. right, at least till 10th of July is what we are having. So the students appearing for the upcoming UPSC CMS exam, that's going to be great for you as well. Okay, so let's start with the discussion of the important topics here. This is going to be a very rapid fire revision, right? So everybody here, okay, so let's start. Transudative pleural effusion versus exudative pleural effusion. First of all, remember that what helps you to differentiate the two is what criteria? It is the Lights criteria. Okay, this is the Lights criteria. I'll share the annotated PDF in the Telegram group, Dr. Nikita's Medsynapse. You can get it from there post class. Okay, right now you just listen to whatever we are discussing. Okay, so you'll definitely get 15 to 20 questions in your FMG exam from the today's discussion. Okay, right. So transudative pleural effusion versus exudative, these are differentiated by Lights criteria. In transudative pleural effusion, where there is increased hydrostatic pressure, it could be a heart failure, a liver failure like cirrhosis, or kidney failure like nephrotic syndrome. So heart, liver and kidney are the causes of transudative. Where do you have exudative pleural effusion? So infection, inflammation, malignancy, that is going to be exudative pleural effusion, right? That is exudative pleural effusion which has high proteins, high LDH. Coming to rheumatoid arthritis, remember in rheumatoid arthritis, what is the most specific antibody that we have? It is anti-CCP. Okay, anti-CCP is the most specific antibody. You have rheumatoid factor as well, the RA factor which is positive. Remember, it is an IgM antibody against IgG. This is very frequently asked question again. Rheumatoid factor is your IgM type of antibody against IgG ka FC receptor, against IgG FC receptor. Rheumatoid arthritis is associated with HLA-DR 4. Remember, rheum has 4 walls, so it is HLA-DR4 that it is associated with. Rheumatoid arthritis never involves what joint? It never involves the DIP. If the DIP is involved, it is not rheumatoid arthritis. Rheumatoid arthritis, does it have erosions? Yes. Any inflammatory arthritis, remember, has erosions. Erosions are suggestive of inflammatory arthritis. Morning stiffness is suggestive of inflammatory arthritis. Remember, morning stiffness is not specific for rheumatoid arthritis. Any inflammatory arthritis can have it. Okay. So this is about this one. Going to next, pneumonia with hyponatremia and diarrhea. This is a classical feature of which organism causing pneumonia? This is Legionella pneumonia. Remember, Legionella has GI in its spelling, so it affects the GIT causing diarrhea, and ON, that is like zero sodium. It causes hyponatremia and diarrhea. In the question, instead of hyponatremia, they can give you altered mental status, confusion. Right, hyponatremia causes altered mental status, confusion. So that is what will be given in the question. Legionella pneumonia, what is the drug of choice? Macrolides, azithromycin is the drug of choice. Legionella also causes Pontiac fever. And remember the culture medium. Okay, what is the mnemonic for culture medium for Legionella? Remember, it is BC, Ye, Lay. So BCYE is for lay, right? All the Ella sisters, Legionella, then you have Pastorella, right? Ella, that is BCYE, buffered charcoal yeast extract. Okay, just give me a minute. Why am I not able to see this? Just a minute. Yeah. All right. I think this is charging as well. So let me see. I was not able to see your chat. Yes. Now, according to the curve 65 criteria as well, when you are suspecting Legionella, remember macrolides hai aur dusra hai levofloxacin. Okay, we add LE, that is levoflox is what is added if you are suspecting Legionella. Okay, levoflox is added if you are suspecting Legionella. Okay, going to the next one. Recurrent pneumonia, steatorrhea, meconium ileus in a child. This is suggestive of cystic fibrosis. Very important topic, cystic fibrosis. Recurrent pneumonia, what organism is common here? Pseudomonas aeruginosa is common, right? Cystic fibrosis causes bronchiectasis. What lobe is involved in cystic fibrosis? It is upper limb bronchiectasis which is there. What test do we do for cystic fibrosis? Remember, it has increased sweat chloride. Okay, it has increased sweat chloride which is present. Very, very important. The gene is the CFTR gene. Remember, it is transporter. What transporter? It is chloride transporter. Cystic fibrosis TR transporter. Remember, C for C, it is chloride transporter. Chromosome number is 7 and inheritance pattern is autosomal recessive. We have discussed all the tricks to remember dominant, recessive, X-linked recessive disorders. Remember, CC wale disorders are autosomal recessive. Sickle cell anemia, hemophilia C, cystic fibrosis, these are autosomal recessive. Tell me a drug which is used in cystic fibrosis. These are the drugs whose spelling ends in Caftor. Remember CFTR, Caftor. These drugs, like you have Ivacaftor. Ivacaftor is a potentiator. Remember, Eva is very potent. Okay, Eva is potent. So Ivacaftor is a potentiator of the chloride transporter, the CFTR. Okay, and the next one, remember the mutation that you have here is delta F508. F for phenylalanine. Okay, which amino acid affected? It is phenylalanine, delta F508. This is for cystic fibrosis. Remember, this is meconium ileus which is present. Can you tell me what happens to the colon in cystic fibrosis? Is it microcolon or is it megacolon that is present? Does it lead to microcolon or megacolon? Meconium ileus, with what do you get in the colon? Micro or mega? Remember, this is microcolon. Okay, megacolon is Hirschsprung's aganglionic megacolon wala. This is microcolon because the meconium ileus, the meconium is not going into the colon, not causing the stimulation of the colon to develop. So remember, it will have microcolon. Okay, there will be microcolon that will be present here. When I said it is causing steatorrhea, so what vitamin deficiency will it cause? Fat soluble vitamin deficiency. Vitamin A, D, E, K deficiency is what you will see here. The fat soluble vitamin deficiency is what we would see here. Okay, is this clear with everyone? Going to the next point, before we go to the next system, one very, very important topic in respiratory system, that is restrictive versus obstructive lung disease. Okay, restrictive versus obstructive lung disease. Remember, in obstructive lung disease, when we say it is the FEV1 which is significantly reduced, the expiration is affected, not the inspiration. So FEV1 by FVC is reduced here, right? Very, very important. What happens to the volumes? The rest of the volumes, like the TLC, the residual volume increases because the air is not going out. So what is happening here is there is air trapping which is present, so these volumes increase. In restrictive, example of restrictive is fibrosis in the lung. It is not allowing the lung to expand, and that is why what happens to the volumes is the volumes are decreased. Like TLC RV is decreased. But what happens to the FEV1 by FVC is normal. Both are proportionately decreased, so it is normal. So asbestosis will be restrictive or obstructive. Remember, it is restrictive disorder. It causes interstitial lung disease, right? So interstitial lung disease. Then you have myasthenia gravis, which is muscular weakness, again restrictive. Asthma, emphysema, all this will come in obstructive lung disease. Okay, that will come in obstructive lung disease. So suppose if I talk about DLCO, okay, this is an important concept. Diffusion, that is a carbon monoxide ka diffusion. So in that case, tell me that DLCO increases where and DLCO decreases where? Asthma, emphysema, where does DLCO increase and where does DLCO decrease? In asthma, the DLCO increases. In emphysema, the DLCO decreases, because remember the destruction of the alveolar wall. So the surface area for diffusion is decreasing in emphysema. In asthma, there is airway ka hypervascularity because of inflammation contributing to DLCO. The DLCO increases there, right? In restrictive, the fibrosis, what happens to DLCO? It decreases. Fibrosis is the thick membrane, so the diffusion will decrease. So remember, interstitial lung disease, the DLCO decreases. What happens to compliance in emphysema? Important, remember, compliance increases in emphysema because the destruction of the elastic tissue, it is not preventing the inflation of the lung. So the compliance increases, but the DLCO decreases. In fibrosis, the DLCO is also decreasing, and the compliance is also decreasing. Remember, the compliance is also decreasing. Is this clear with everyone? Okay? Alright. Going to the next topic, coming to some important topics in cardiology. Remember, constrictive pericarditis. I want you to remember this with constrictive pericarditis, the K and the K. What are the two Ks that you see with constrictive pericarditis? Remember, there is pericardial knock and there is cusmols which is present. Okay, pericardial knock and cusmols. Frequently asked a UPSC CMS question as well. Cusmols is seen in which type of cardiomyopathy? Restrictive, dilated, hypertrophic, obstructive. Where do you have cusmols present? It is restrictive cardiomyopathy. Okay, like any cause of fibrosis, amyloidosis, that is restrictive cardiomyopathy, you will have cusmols which is present there. In constrictive pericarditis, what do you have in the JVP? Remember, constrictive pericarditis, CP is CP, it is combined present. Both are present. That means the X descent and the Y descent both are present. You get the M pattern here, which is the steep Y descent. Okay, the steep Y descent. So that is what you see in constrictive pericarditis. Coming to next one, drugs decreasing mortality in heart failure. Does digoxin decrease mortality? No. Remember, when you want to decrease mortality in heart failure, basically you have to prevent the remodeling of the heart. What is the remodeling done by? The sympathetic system and the RAS system. So you have to block the sympathetic system. So beta blockers will come in here. You have to block the RAS. So it is ACE inhibitors, it is spironolactone which comes here, which are going to decrease the mortality. Remember, digoxin does not decrease the mortality in heart failure. Digoxin does not decrease mortality. We use digoxin in heart failure because basically it increases the intracellular calcium in the heart, and that is how it increases the contractility of the heart. How does it increase the calcium? Is by inhibiting the sodium potassium ATPase. So what electrolyte abnormality increases digoxin toxicity? Very, very important. Remember, hypokalemia increases digoxin toxicity. Digoxin and potassium are competing to bind to that sodium potassium ATPase. If you decrease the potassium, the digoxin is happy and gets excited, and there's a lot of toxicity. So any drug causing hypokalemia, any condition causing hypokalemia like furosemide, okay, a loop diuretic like furosemide, you will not use with digoxin. Okay, you will not use with digoxin. Is this clear with everyone? Right? So this is what we need to know here. Very, very important. Going to the next concept here. Bedridden patient now complaining of breathlessness and chest pain. What is the diagnosis? Bedridden patient, whenever it is given, you are thinking of DVT. Breathlessness and chest pain is pulmonary embolism which has developed. Okay. So what is the investigation of choice there? The first investigation, the screening test that we do is D-dimer. Okay, the screening test is the D-dimer. But then the investigation of choice, if the D-dimer is high, you go for CT pulmonary angio. If CT pulmonary angio is not in the option, then you will go with CECT. Okay, then you will go with CECT, contrast enhanced CT. You will never do a non-contrast CT for a vascular pathology. Now, suppose the same question, they tell you that there is DVT, but now instead of the pulmonary embolism, recent MCQ marathon, in-app live session we have discussed, DVT के बाद अगर stroke हो रहा है, then what is the diagnosis, guys? Let me see who remembers. The Medsynapse subscribers here. DVT leading to stroke, not to pulmonary embolism. What is the diagnosis there? Doppler is done for looking at the DVT per se. If they ask you that investigation of choice for DVT, then there's going to be Doppler. If DVT is leading to stroke, so basically it is right side se left side ja raha hai embolism. So there is some defect in the septum in between the two. Very good. Then that becomes a diagnosis of paradoxical embolism due to a defect present like patent foramen oval, atrial septal defect, ventricular septal defect. That is what is going to be present. And what do you see with atrial septal defect? Remember ASAS as it is S2 split. ASAS as it is S2 split. That is fixed split of S2. Wide fixed split of S2 which does not change with inspiration expiration. Okay. Next one. Going to this one, right heart failure versus left heart failure. Clinically, how do you differentiate? So understand the concept that in the heart, we have the right side and the left side. What drains into the right side is superior and inferior vena cava. What drains into the left side is the pulmonary veins. So when the right side fails, it is the superior vena cava, inferior vena cava where the congestion is happening. So superior vena cava, the JVP will be high. Inferior vena cava going through the liver, there's going to be hepatomegaly, there's pedal edema. While in the left heart failure, there's going to be pulmonary edema. The back pressure going to the lungs, pulmonary edema. So that's how we differentiate the two. In right heart failure, it is pedal edema that will be present. In left heart failure, it is pulmonary edema that will be present. Right heart failure will have raised JVP, hepatomegaly that will be present. Okay, so when they give you crackles, suggestive of pulmonary edema, that is left heart failure. Now, smoker, COPD patient getting heart failure will get what side heart failure? Right side or left side? Smoker will get what side? Right heart failure. Why? Because in the lungs, the obstructive pathology increasing the pressure in the lung, back pressure will go to the right side of the heart. From the pulmonary, it will go to the right side, right heart failure, which is called as cor pulmonale. So, pulmonary disorder leading to cor, that is coronary failure, that is cor pulmonale. Okay, that is cor pulmonale. Okay, is this clear with everyone? Okay, right. Going to next one, ECG findings. Where do you see absent P waves? The P wave is due to atrial depolarization. So, absent P waves, no atrial contraction. This is going to be seen in atrial fibrillation. Can it be seen anywhere else? Yes, PSVT also has absent P waves. The difference is atrial fibrillation is irregular rhythm. PSVT is going to be a regular rhythm. Okay, PSVT is going to be regular rhythm, right? So, this is about absent P waves. Delta wave, where do we see? WPW syndrome. Wolff-Parkinson-White syndrome shows delta wave. Osborne O is hypothermia. Okay, they're seen in hypothermia. Drug of choice in PSVT is IV adenosine. Okay, this IV adenosine. If the patient is unstable, anytime patient with arrhythmia, unstable patient, always you have to go for cardioversion directly. You will not give the drugs, you'll directly go for cardioversion. Okay, clear with everyone? Where do you see Beck's triad? Very, very important. This is seen in cardiac tamponade. Okay, this is seen in cardiac tamponade. What is the Beck's triad? Remember, veins draining into the heart, from there the artery coming out. So, veins, heart and artery. So, the veins are full, that means raised JVP. Heart mein there is muffled heart sounds. Arteries mein there is decreased pressure, decreased blood pressure, hypotension. This is the triad of cardiac tamponade. Does cardiac tamponade cause shock? Yes. It causes what shock? It causes obstructive shock. Okay, it causes obstructive shock. The tamponade, the fluid obstructing the heart, obstructive shock, which can also be seen in pneumothorax, right? Excessive air compressing the heart, also in pneumothorax. So what is the key word to differentiate cardiac tamponade versus pneumothorax? Remember, tamponade mein the heart sounds are muffled, the breath sounds are normal. In pneumothorax, there will be decreased breath sounds, क्योंकि ये plural, lung के आसपास की pathology है, and the note that you will get is hyper resonant note. On percussion, there will be hyper resonant note. Okay, so that is how you'll differentiate the two in a patient of trauma, whether it is tamponade or it is pneumothorax. What do you see in ECG in cardiac tamponade? Because the heart is floating in the fluid, right? So it gives electrical alternance, electrical alternance. The heart coming in front, going back, the amplitude changing in the ECG, electrical alternance. Versus where do you see pulsus alternance? Pulsus alternance is seen in left ventricular failure. Okay, that is seen in left ventricular failure, right? Coming to some important ECG findings, let us quickly revise this. Tell me what is this ECG suggestive of? There is tachycardia, the RR is close. You are not seeing the P wave, it's a regular rhythm. This is PSVT. Okay, this is PSVT. If the patient is stable, you will do the vagal maneuvers, the carotid massage, and the drug would be adenosine, right? If the unstable patient, then you will go for cardioversion directly. What are we seeing here? Look at the RR. It is irregular and you are not seeing the P wave. The baseline is not there. This is atrial fibrillation. Okay, this is atrial fibrillation. Rhythm control, rate control, right? And anticoagulation is what we use here. Okay, so cardioversion, anticoagulation is required in atrial fibrillation. Depending on what score do we use here? The CHADS-VASc score. Okay, the CHADS-VASc score tells you that whether anticoagulation needs to be given or not. When you give anticoagulation here, remember the drug preferred is a NOAC, newer oral anticoagulant. But if it's a valvular pathology, like valvular mitral stenosis, rheumatic heart disease, valvular prosthesis, in that case, remember VA, then you need to give warfarin in that case. Which is the oral direct thrombin inhibitor? Remember, it is dabigatran. Which are the other oral inhibitors, the NOACs? It is factor 10A inhibitors. Okay, it is factor 10A inhibitors. Is this clear with everyone? Right? Give me a quick thumbs up if this is clear with everyone. I hope I'm able to see the... Yeah. Next one. What are you seeing here? Relatively regular rhythm is what you are seeing here. And you are seeing this sawtooth wala appearance, the sawtooth waves. This is going to be atrial flutter. Okay, this is going to be atrial flutter. Management is similar to atrial fibrillation. Look at this one when you have the broad QRS like this. Broad QRS. Remember broad QRS, this is going to be ventricular tachycardia, which is monomorphic ventricular tachycardia. Where else do you have the broad QRS? The bundle branch blocks also. Okay, the bundle branch blocks. Wherever there's an abnormal pathway activation, it's a broad QRS. Ventricular tachycardia, the drug that you give is amiodarone. For sustained ventricular tachycardia, there you need to do cardioversion there. Okay. Next one. What are you seeing here in this image? Look at this one. Very low amplitude waves. You are hardly seeing anything. This is ventricular fibrillation. You need to do defibrillation here. Okay, you need to do defibrillation. Which are the non-shockable rhythms? You cannot give shock there. Non-shockable rhythms are asystole and pulseless electrical activity. Pulseless electrical activity means what they give you in the question is the ECG is normal but there is no pulse. That is what is given in the question. So what is going to be the drug of choice in that condition? Remember, the drug of choice is epinephrine. For non-shockable rhythms, you give epinephrine. Okay. Whenever you have a COPD patient with ECG, they are pointing towards MAT, multifocal atrial tachycardia. Okay, so COPD with ECG is generally MAT. Going to next one, where you have this twisted ribbon appearance which you are seeing here. The twisted ribbon appearance, this is going to be Torsades de Pointis, Torsades de Pointis, where the drug of choice is IV magnesium sulfate. What leads to Torsades de Pointis? Hypokalemia, hypomagnesemia, hypocalcemia. What predisposes? QT prolongation. It is QT prolonged leading to Torsades de Pointis. What are we seeing here? The sloping of the QRS here. This is the delta wave of WPW syndrome. How is the PR interval in WPW? It is short PR because the bundle of Kent is faster conducting, right? And what do you have in the QRS? The QRS is a broad QRS because again this is abnormal pathway. Okay, again this is abnormal pathway. The definitive treatment here is the ablation of the accessory bundle of Kent. You will not give any drug which blocks the AV, like digoxin you will not give here. It blocks the AV. So no AV blockers because otherwise the bundle of Kent will become dominant. So no AV blockers are to be given here in WPW syndrome. Okay, the PR is short, the QRS is broad. Going to next one in the AV block. Mobitz type 1, Mobitz type 2. These are second degree block. In AV block, first of all remember that in AV block the primary change is PR is prolonged because it takes a longer time to conduct. So that is PR prolongation. If you have PR prolongation with a drop, remember DO, drop DO, it is second degree block. Drop is a second degree block. So in second degree you have Mobitz type 1. Remember 1 is Vankeback. Vankeback is Mobitz type 1. What do you have there is a drop and the PR interval you can see is progressively increasing and then there is a drop. So progressive increase. In Mobitz type 2 the PR is increased but it is constant increase and you have a drop present, right? So this is Mobitz type 2. Okay, here you have the P and then there is a drop here. This is 2:1 block. Okay, this is 2:1 block that you are seeing here. 2 P waves and then 1 block, 1 drop there. 2:1 block. What is the drug of choice in AV block? Like first degree AV block. What is going to be the drug of choice? Antiparasympathetic, that is atropine. Okay, for AV block we will use atropine. What drugs cause AV block? Remember A, B, C, D. Beta blockers, calcium channel blockers and digoxin. They cause AV block. Okay, these are the drugs which cause AV block. You will not use them. Okay, right. Complete AV dissociation is seen in type 3. It's a complete heart block. Atrium on its own, ventricle on its own. How is the RR interval in the third degree block? Remember the RR is constant, the PP is constant, but there is no relation between P and R. Atrium and ventricle are not related, right? So RR is going to be constant. Okay, PP is constant, RR is constant. Going to next one, what is this one? Which wall MI is this? Where are you seeing the ST elevation here? Which wall MI is this? So in the leads 2, 3 AVF you are seeing here. This is 2, 3 AVF. 2 feet, 3 and AVF. Remember feet wala. Where is the foot present? Inferior. So that is inferior wall MI. Plus you see this ST depression in the V1 and V2. The V1 and V2 are showing ST depression. What is that suggestive of? Reciprocal changes of posterior wall MI. So remember the right coronary artery when blocked, the right coronary artery supplying inferior and posterior wall, generally they go hand in hand. So inferior wall MI 2, 3 AVF. Remember in inferior wall MI there is hypotension and there is bradycardia. In the treatment you need to give IV fluids and atropine. Okay, whenever there is bradycardia you will give atropine. So that is how the treatment is different from the rest of the MI. Okay, the rest of the MI. Right. Going to next one, neurologica important points. What is that condition where there is ascending areflexic motor paralysis? Remember ascending areflexic motor paralysis. This is flaccid paralysis. This is GBS. Guillain-Barré syndrome. What is the cause of death here? The ascending leads to the involvement of respiratory muscles. Then there is respiratory failure here. Okay. GBS is associated with Campylobacter jejuni. Okay, Campylobacter jejuni. Which is the descending wala paralysis? Descending is botulism. Okay, remember botulism is descending. Fatigue ptosis more in the evening. Classical of myasthenia gravis, increases with exertion, so more in the evening. So myasthenia gravis, very important drug used for treatment, remember, is pyridostigmine. Pyrido helps the patient get rid of myasthenia gravis. Okay, pyridostigmine. Okay, and myasthenia gravis. Myasthenia gravis has antibodies against acetylcholine receptor, postsynaptic acetylcholine receptor. Multiple episodes of neurological deficit and optic neuritis. This is multiple sclerosis. What do you see in CSF with multiple sclerosis? The oligoclonal bands. Okay, oligoclonal bands are seen in CSF. What is the investigation of choice? MRI with contrast. It will show the demyelinating plaques, whether they are active, acute ones, or they are the chronic ones. That is what you'll see in MRI, McDonald's criteria. What sign does the MRI show? The Dawson fingers. Okay, it will show the Dawson fingers. What interferon do you use for multiple sclerosis? That is interferon beta. Okay, interferon beta. Natalizumab causes PML. Okay, that is used for multiple sclerosis. Okay, yeah. Recurring headache with positional and diurnal variation in an obese female on OC pills. What is the diagnosis here, guys? In an obese female, you have recurrent headaches with positional variation. This is classical of idiopathic intracranial hypertension, that is pseudotumor cerebri. Okay, that is pseudotumor cerebri, obese female, OC pills, hypercoagulable state. The sinus thrombosis occurring can lead to the increased intracranial pressure. So, pseudotumor cerebri. It is also seen with toxicity of what vitamin? Vitamin A. Okay, that is vitamin A. Okay, right. Next one, CSF meningitis and TB meningitis. Classically, what you will see, the lymphocytes are increased. There is cobweb coagulum formation. On radiological imaging, you would see a lot of basal exudates. Okay, you will see a lot of basal exudates. Viral again has lymphocytes increase, but most important, remember, like viruses do not eat glucose. So, very important clue is, if the glucose is given normal in the CSF, it is viral meningitis. Normal glucose is viral. Cryptococcal meningitis, the drug of choice is amphotericin B plus flucytosine, not fluconazole. Later on in the maintenance phase, then you give fluconazole, but initially it is amphotericin B with flucytosine. Cryptococcal, this is an opportunistic infection, so HIV positive patient, this will be common. When there is involvement of paracentral lobule, what clinical features the patient will have? Remember, paracentral lobule is on the medial surface, which is supplied by anterior cerebral artery. Okay, so remember, paracentral lobule, P and L, that is what it affects. The perineum and the legs. When I say perineum, urinary bladder affected, that's going to be urinary incontinence with lower limb weakness. Paracentral lobule, the medial surface of the brain is ACA. So, when there is ACA infarct, remember the lower limbs are involved more than the upper limbs. When there is hemiplegia, there is aphasia, it is going to be what artery? It is going to be MCA artery, middle cerebral artery, right? Blindness, visual complaints is going to be PCA infarct. Okay, that's going to be PCA infarct. What is the contraindication for thrombolysis? Hemorrhagic stroke. You do not give thrombolysis in hemorrhagic stroke, remember, and therefore the first investigation in any patient of stroke has to be non-contrast CT to identify whether there is hemorrhage. There is no hemorrhage. If there is a hemorrhage, you will not give thrombolysis. You need to control the blood pressure, give mannitol, but no thrombolysis there. Thrombolysis needs to be given within 4.5 hours. Okay, within 4.5 hours, you need to give thrombolysis. Right, and remember to decide that TIA converting to stroke. What is the risk? What score do we use here? ABCD2 score. It is the ABCD2 score which is used to identify what is the risk of TIA converting to stroke, right? So remember age, blood pressure, clinical features, and you have the duration which is important here. Okay, the duration, diabetes, that is important there, right? Going to next one, endocrinology. Drugs used in treatment of which condition? Lanreotide, octreotide, somatostatin wale hai jo. So remember these are used in acromegaly. Okay, these are used in acromegaly. Lanreotide, octreotide. Pegvisomant, again som antagonist, somatic growth ka antagonist. So this is also used when the growth hormone is high, that is acromegaly. Terlipressin, like vasopressin, but this is the one which acts on the ADH ka V1 receptor on the blood vessel, causing the vasoconstriction. So this is used for variceal bleed. This is used for variceal bleed. While in diabetes insipidus, what drug do you use in diabetes insipidus? It can be central diabetes insipidus, nephrogenic diabetes insipidus. For central, when it is deficiency of ADH, you will supplement the ADH by giving desmopressin. And when it is nephrogenic, we give thiazides. We give thiazides. Except where do we not give thiazides? Remember, lithium induced diabetes insipidus, because thiazides increase lithium toxicity. Remember that point. So you do not give thiazides there. What do you give there? Li is amiloride. LIIL. Amiloride is given there. Okay, amiloride is given there. Is this clear with everyone? Right? Going to next one. What is this diagnosis here? Sudden onset headache, palpitations, sweating with elevated urinary metanephrines. This is classical of pheochromocytoma. Pheochromocytoma, which is a tumor of adrenal cortex or adrenal medulla. This is adrenal medulla, right, which develops from neural crest cell. In which men syndrome do you have pheochromocytoma? Neural crest cell wala is MEN2. MEN2 has which other thyroid cancer? Remember, MEN is MED. It is medullary thyroid cancer. Neural crest cell से जो आता है वो tumors आते हैं यहाँ. For pheochromocytoma, the investigation of choice is MRI. You want to see for adrenal gland? You do MRI there. It shows the light bulb sign on T2 weighted MRI. For extraadrenal pheochromocytoma, which can be 10%, the rule of 10, you will use MIBG scan, which will scan the pheochromocytoma everywhere. Okay, MIBG scan for extraadrenal. Okay, so that is pheochromocytoma. Next one, abdominal cramps, bone pain, nephrocalcinosis and abnormal behavior. Right? Stones, moans, groans, bones. Right? All this is classical of hyperparathyroidism. Hyperparathyroidism. Very, very important question. What nuclear scan do we do here? It is SISTA-MIBI scan. In the question, sometimes they might just give you the MIBI scan. MIBI, MIBI scan, SISTA-MIBI scan is used here. Hyperparathyroid, parathyroid hormone, what does it cause to calcium and phosphorus? Remember, PTH has opposite actions. What opposite actions? It increases the calcium, it decreases the phosphorus primarily, right? But if it is secondary hyperparathyroidism, which is seen in renal failure, it has opposite hypocalcemia and hyperphosphatemia. Okay, this is what stimulates the parathyroid. So in secondary, you have hypocalcemia. In primary, you have hypercalcemia. Okay, in primary, you have hypercalcemia. Pancreatic neuroendocrine tumors, where do you see Whipple's triad? Remember, it is seen in insulinoma. That is decreased glucose, symptoms of decreased glucose, you give glucose and it becomes normal. NME, necrolytic migratory erythema. Migratory erythema, that is going here and there. Right? Which tumor has this necrolytic migratory erythema? That is glucagonoma. Okay, remember glucagonoma. This is the one which has gone, the erythema which is gone here and there, going here and there. Glucagonoma has this necrolytic migratory erythema. Watery diarrhea with hypokalemia and achlorhydria. This is seen with VIPoma, V and W. Okay, watery diarrhea, VIPoma. This is seen with VIPoma. Remember, it causes hypokalemia and achlorhydria. Okay, hypokalemia and achlorhydria. Diabetic ketoacidosis, which is HUGMA, that is high non-gap metabolic acidosis. And remember, there will be fruity odor of the breath that will be mentioned here. There will be Kussmaul's breathing mentioned here. So the drug of choice is you give IV fluids plus regular insulin. Okay, IV fluids plus regular insulin is what you give here in diabetic ketoacidosis. Is this clear with everyone? Right? Okay. Going to the next one, hematology. In which condition do you do elective splenectomy? Prophylactic splenectomy is done for hereditary spherocytosis. Hereditary spherocytosis, we do elective splenectomy. When we are doing splenectomy, you need to give what vaccines to the patient? Encapsulated organisms like pneumococcal vaccine, right? The Neisseria का देना पड़ेगा और दूसरा कौन सा है? Meningococcal, then you have pneumococcal and you have Haemophilus influenza. Okay, meningococcal, pneumococcal and Haemophilus influenza का vaccine देना पड़ेगा. And where do you have versus where do you have autosplenectomy? Where do you have autosplenectomy? The spleen gets automatically removed because of the infarct happening. Infarct का होते हैं sickle cell anemia. Okay, that is sickle cell anemia. Remember, very important, sickle cell anemia is what kind of mutation? It is point mutation. What kind of point mutation? Missense mutation. Okay, it's a point mutation, a missense mutation. Next one. Classical hemolysis precipitated by oxidative stress, anti-malarial drugs like primaquine. This is G6PD deficiency, which is what inheritance pattern? Remember XLR. We have discussed the mnemonics again. 6 goons, X-linked recessive inheritance. You see Heinz bodies and Bite cells here. Heinz bodies and Bite cells. Dark brown urine in the morning. This is paroxysmal nocturnal hemoglobinuria, and that is why in the morning the urine is brown. Why nocturnal? Because at the night the complement gets overactivated. So basically this PNH is because of complement overactivation. Why is the complement overactivated? Because there is deficiency of CD55, CD59, which are complement inhibitors. Right? So they are not there, so the complement gets overactivated. So therefore in the management, in the drug, which monoclonal antibody do you give? You want to inhibit the complement, you give a C5 inhibitor, which is what drug? Eculizumab. Okay, what do we give here is eculizumab. Remember E5 and C. Okay, that is 5C, inhibiting C5. Eculizumab. What gene is affected here? The PIGA gene. Okay, the PIGA gene. Next one that you have TRAP positive, tartrate resistant acid phosphatase, not alkaline phosphatase. There is splenomegaly, there is pancytopenia, but there is no lymphadenopathy. This is hairy cell leukemia, classical hairy cell leukemia. Hairy, what is the drug of choice in hairy? Remember, a person clad with hair. So the drug of choice is cladribine, clad with hair. Hairy cell leukemia affects what pulp in the spleen, the white pulp or the red pulp? Remember, hair is red colored. That's the new normal, not the white or the black. It is red color. So it affects the red pulp of the spleen. Right? And what is the CD marker specific here? Remember this as 1, 0, 3. Okay, these are the hair, the red hair. This is 0 and the ears are the 3. So 1, 0, 3. This is the CD marker specific for hairy cell leukemia. CD103, you have 25C11 वगैरह वो आएगा. कौन सा annexin positive होता है ये? Annexin A1, not annexin A5. Remember, hairy cell leukemia is A1. Hairy is AI, it is A1 positive. Vitamin B12 deficiency, folic acid deficiency, both of these will lead to megaloblastic anemia with hypersegmented neutrophils. The difference in the clinical manifestation is vitamin B12 will have neurologic complaints, folic acid will not have neurologic complaints. What neurologic comes here? SACD, subacute combined degeneration of cord, which predominantly affects what part in the spinal cord? It is the dorsal column. It predominantly affecting the dorsal column, and that is why there's going to be loss of vibration and proprioception. Loss of vibration, proprioception will be there. In B12, methylcobalamin has methylmalonic acid increasing. Increased methylmalonic acid will be there. In folic acid, the methylmalonic acid will not be increased. Both of these will have increased homocysteine, right? Homocysteine increases in both B9 and B12 deficiency, right? Vitamin B12 deficiency will be seen in a vegetarian diet wala person. Folic acid deficiency will be seen in a person not eating leafy vegetables. So junk food, somebody eating junk food, उसमें दिखेगा, ठीक है, वो उसमें दिखेगा. Next one, where do you see Casal's necklace? Since you are seeing vitamins, remember that dermatitis wala pellagra. Okay, pellagra, vitamin B3 deficiency. Remember B3 is tri. This is the one which is synthesized from tryptophan. From B3 is synthesized from tryptophan. Very, very important. Next one, basophils are increased in which leukemia? Increase in basophils is CML. Okay, basophils are increased in CML, which most commonly has Philadelphia chromosome, which is translocation 922. Translocation 922, which leads to increased tyrosine kinase activity, and that is why the drug that you give here is imatinib. The drug of choice here is imatinib for CML. Okay. CRAB features in elderly. What does this CRAB stands for? Hypercalcemia, renal failure, anemia and bone pains. Okay, anemia and bone pains. Classically, this is seen with multiple myeloma, which is a tumor of plasma cells. Okay, tumor of plasma cells. In multiple myeloma, very important, remember how is the alkaline phosphatase? The alkaline phosphatase is normal. Why? Because there is no new bone formation. The calcium is high, but the alkaline phosphatase is normal. Versus opposite, where the alkaline phosphatase is very high, the calcium is normal. This is seen in what condition? This is seen in Paget's. This is seen in Paget's. In Paget's, the alkaline phosphatase is high. Where do you have all normal? Calcium, phosphorus, alkaline phosphatase, everything is normal. In which bony condition? Osteoporosis. It is osteoporosis. So we diagnose osteoporosis by bone mineral density, which is done on the DEXA scan, not the bone scan. It is DEXA scan which is done for osteoporosis. Is this clear with everyone? I hope everybody is good with the speed that we are going with, because this is like your last minute revision. So, right, we cannot go like very, very slow. Everybody is fine with this? Give me a quick thumbs up. Yes? All right, that's great. Going to the next one, some important points in anemia. In anemia, remember what are the causes of microcytic anemia? Remember, Sita is microcytic. Okay, so which one causes microcytic, which does not cause microcytic? Sita is microcytic. Sideroblastic, iron deficiency, thalassemia and anemia of chronic disease. In iron deficiency anemia, most important, remember TIBC increases. TI at the top in iron deficiency anemia. TI at the top in iron deficiency anemia. Okay. And in anemia of chronic disease, which has inflammation, what is a positive acute phase reactant? Increases in inflammation. Ferritin will increase. Ferritin increases in anemia of chronic disease. Okay. In thalassemia, a genetic defect, the RDW is normal. All the red cells are of the normal size. The same size. And remember that the Menzer index, TZER, in thalassemia TZER 0, the Menzer index decreases. In thalassemia, it increases in iron deficiency anemia. Okay, right? This is about this one. The most important point here in iron deficiency anemia, remember TIBC increases and the ferritin is less. The stores are decreased. While in anemia of chronic disease, the ferritin is high. Okay, the ferritin is high and the TIBC is decreased. Okay, is this clear with everyone? Right? What screening test do you have for thalassemia? Remember, there's a test which is called as Nest-Roft test. Okay? Nestrov is for thalassemia. Going to next one, lymphoma mein, what lymphoma is this? Where you see this starry sky appearance. Starry sky appearance, stars, bhar ke stars, bhar ke is Burkitt's. Remember, bhar ke stars is Burkitt's lymphoma, has starry sky appearance. Classically, they'll give you jaw swelling in a child from Africa. Remember, Burkitt's, B is 8. It is chromosome 8 because what gene is affected? The c-MYC gene is affected. So, all the translocations will have 8. Translocation 28, translocation 8, 22, translocation 8, 14. All the even numbers, 2, 8, 14, 22. There's no 8, 21 there. Okay. So, remember, you will have, this is Burkitt's lymphoma. Burkitt's lymphoma is associated with Epstein-Barr virus. Okay. It's a B-cell lymphoma, Epstein-Barr virus. Where you have this cytoplasmic, the projections here, this is hairy cell leukemia. We have already discussed this. Where you have this owl-eye appearance, these are the Reed-Sternberg cells of Hodgkin's lymphoma. Hodgkin's lymphoma, Reed-Sternberg cells. Remember, classical one is CD1530 positive, which is the non-classical, which is CD2045 positive, lymphocyte predominant. It is non-classical one. Remember, lymphocyte predominant P for P, it has the popcorn type of Reed-Sternberg cell. In Hodgkin's lymphoma, they give you the history of the lymph nodes, night sweats, right, fever, weight loss, which is present, and there will be increased eosinophils. This is also associated with Epstein-Barr virus. Okay, this is also associated with Epstein-Barr virus. Okay, right. Going to next one, can you tell me what leukemia is this? What are you seeing here? What leukemia is this one? Where you have a cell which is smudged cell, this is seen in CLL. Okay, this is seen in CLL. Remember that CLL is an elderly patient who is very excited, enthusiastic. He decides to fly in the parachute and the parachute gets smudged. It gets deflated, it gets smudged, right? So, this elderly patient flew in the parachute and got smudged. This is like khud ke pair pe kuladi marna. That is an autoimmune, like an autoimmune condition. So, remember, autoimmune hemolytic anemia is associated with CLL. What is the flu here? Remember, flu is the drug of choice. That is fludarabine. Okay, that is fludarabine. Flu and flow. What is the investigation that you do here? Flow cytometry. Why do you do flow cytometry, the investigation of choice here? Because it is combined positive, CLL-C for combined positive, CD5 positive and CD23 positive. It is both positive. Okay, it is both positive. That is CD5 and CD23 positive, right? All the elderlies in our mnemonics, right? Be it this elderly man or a grannies, they are all excited. Okay. Next one, when you have a question like this, the images itself is telling you what is the diagnosis. When you see this OR rods here, OR rods are seen in AML. OR rods are seen in AML. Remember, M myeloid, this is going to be myeloperoxidase positive. Which one has DIC? Remember, 3 words, 3 letters, DIC. This is AML subtype M3. Remember, in M3, 3 के table में क्या आता है? 15. You have translocation 15, 17. This is APML, right? RAR wala translocation which is there. Remember, in AML subtype M3, 3 is tri and tra. What do we use in the treatment? Atra, all trans-retinoic acid, and arsenic trioxide. Okay, we use arsenic trioxide and atra here. Arsenic trioxide and atra. Okay, this is promyelocytic, APML, promyelocytic. Okay, so this is AML. And if you have a leukemia ka question telling you that there is mediastinal mass, what kind of leukemia are they talking about when they tell you mediastinal mass? Mediastinum mein aata hai thymus. Remember, thymus matlab T cell. So basically they are talking about TALL. Okay, they are talking about T type of ALL, T subtype of ALL, mediastinal mass. Okay, right. Going to next one, the coagulation disorders, most important that I wanted to discuss here. If it's a platelet disorder, what is increased PT or APTT? it is BT increased, right? Like an immune thrombocytopenic purpura, it is the bleeding time which increases. Coagulation disorder, extrinsic pathway, intrinsic pathway, right? Now remember that when the mnemonic here is wept and happy, okay, the two opposite emotions, happy and wept. Warfarin, extrinsic, you monitor PT. Heparin, APTT, intrinsic. Okay, so with warfarin, extrinsic PT, with heparin, APTT, and this is a marker of intrinsic pathway. Which is a coagulation factor, which is extrinsic, only extrinsic. Remember factor 7. Remember it as 7 is in the heaven, extrinsic, world ke bahar. Factor 7, tissue factor wala. Okay, that is tissue factor. So remember with heparin, you will have APTT to be monitored. Hemophilia, like hemophilia A, factor 8, intrinsic pathway affected. There is APTT which is prolonged. Okay, there is APTT which is prolonged. Von Willebrand disease. Remember this von Willebrand factor is important for platelet adhesion and also for stabilizing factor 8. So that is why platelet wala affected bleeding time bhi badega or APTT bhi badega. Very, very important. When both are increased, it is von Willebrand disease. And what do you give in the treatment here? You give desmopressin because it increases the release of von Willebrand factor from the endothelium. Okay. So remember this is both increased. Okay. This is both increased. Okay. Clear with everyone? Look at the question here. This is how the questions come and all you have to see is bleeding time, PTT, both are increased. This is nothing but von Willebrand disease. जब दोनों बड़े रहेंगे, it is von Willebrand. Bernard-Solier is a defect in platelet. Remember AD, it is a defect in platelet adhesion, GP1B9, Bernard-Solier. While Glanzmann, remember Glanzmann, GG, this is a defect in platelet aggregation, GP2B3A. Okay, that is what is required for platelet aggregation. Can you tell me the drugs acting on GP2B3A? We have discussed this anticoagulant, ye wala pura drugs in our short course online also in the app. GP2B3A. Remember Fib wale drugs या ABBA wale drugs. Like Fib wale jaise tirofiban. This is Fib. Okay, this is Fib. Then you have eptifibatide. Okay, eptifibatide. Again Fib because fibrinogen is important for that platelet aggregation. Then you have this AB wala drug which is apcizimab. Apcizimab is GP2B3A. So apcizimab, tirofiban and eptifibatide, these are GP2B3A, not tranexamic acid. Tranexamic acid is antifibrinolytic. Okay, tranexamic acid is antifibrinolytic. Yes. Okay, so that is done. Going to rheumatology now. Whenever you see this classical lilac rash, heliotrope rash, Gottron's papules, mechanics hands, this is dermatomyositis which has anti-Jo. Okay, remember Jo is a female. The name of this female is Jo, has dermatomyositis in a female. What cancer you will look for? Ovarian cancer. Okay, CA125 is what you need to look for. Next one, when you have this spine which is fused, okay, when you have this dagger sign, the spine which is fused, ankylosing spondylitis, ankylosing with the fusing spondylitis. What HLA it is? HLA B27. Ankylosing spondylitis can have red eye. Why? Because uveitis is a common extra-articular manifestation. Where does it start? It starts at the SI joint, the sacroiliac joint, low backache, and then it goes upwards. The entire fusion happens. Ankylosing spondylitis. Next one, when the great toe is affected. Remember, great toe affected, GTO is gout. GTO is gout. First MTP is affected. In an acute attack, what drugs do you use is NCC. That is NSAIDs, colchicine and corticosteroids. What do you not use in acute attack is allopurinol. Okay, NSAIDs mein what will you not use? Aspirin is not given. Aspirin, alcohol, precipitate gout. Remember alcohol ka history rahega precipitating the gouty attack. Okay, very, very important, right? Very important. Yes. Whenever they give you this first CMC joint is affected, first CMC affected, you think of osteoarthritis. Can it involve the DIP? Yes, it can. You have Bouchard's nodes and you have Haberden's nodes. Haberden's and Bouchard's, remember this is high definition BP, HDBP. Haberden's at DIP, Bouchard's at PIP. Okay, Haberden's and Bouchard's nodes, osteoarthritis. Okay, osteoarthritis. Okay? Right. And in rheumatology, coming to some connective tissue disorders ka quick discussion. Whenever they give you dry eyes, dry mouth, what disorder is it? That is Sjogren's, keratoconjunctivitis sicca. What test do you do for dry eyes? That is the Schirmer's test. Okay, that is the Schirmer's test that you will do for dry eyes. Next one, when they give you Raynaud's. Okay, Raynaud's esophageal dysmotility, they are talking about scleroderma, right? The Crest syndrome, limited scleroderma or scleroderma. What antibody do you have here in scleroderma systemic? Remember NTSCL, scleroderma, that is topoisomerase 1. Crest C4C has anti-centromere C4C. Sjogren's has what antibodies? Sjogren's has anti-Rho, anti-La. Anti-Rho, anti-La, SSA, SSB. Sjogren's syndrome A, Sjogren's syndrome B, that is how you can remember. SSA, SSB. Anti-Rho, anti-La. This is NTSCL and this is anti-centromere. Okay, that is anti-centromere. If there is the butterfly rash, malar rash, butterfly, malar rash, it's a diagnosis of SLE. The screening test is ANA. The specific antibody is anti-Smith and the disease activity is given by double-stranded DNA, anti-dsDNA. Antibody tells you, DSDS tells you the disease activity. What happens in SLE is complement levels decrease. The C3, C4 levels are decreased. Okay, C3, C4 levels decrease with SLE. Okay, very, very important. And when you have drug-induced SLE, what antibodies? When it is drug-induced, you take drug history. So remember, it is anti-histone antibodies. What drugs are those? SHIP, sulfonamides, hydralazine, INH. And what does P stand for? Procainamide. Remember the antiarrhythmic drug procainamide, it's not procaine or phenytoin. It is procainamide. Which TB drug? It is INH. Which TB drug? It is INH. Okay, clear with everyone? Right? So, going to the next system. Give me a quick thumbs up before we go to the next system. That is a hepatobiliary system. Yes? Great. Going to the next one. Hepatobiliary pancreas, the child score. What is the child score used for? Child cirrhosis. Remember, child score is used for cirrhosis. Cirrhosis ka severity. Compensated hai, decompensated hai. What are the components of the child score? Components of child score is, remember, every child has ek baap. That is a mnemonic for child score. Ek baap. EBAAP. That is encephalopathy, bilirubin. Then you have A for albumin. Another A for ascites. Remember, cirrhosis has ascites. CICI. Albumin ascites. And you have PTINR. What is not there? AST, ALT is not there. Creatinine is not there. Okay. AST, ALT is not there. Creatinine is not there. Okay. I'll share the PDF post class on the Telegram group. Annotated PDF I'll share. Okay. Right. Pruritus, grey colored stools. What is this suggestive of? Grey colored stools with pruritus. This is suggestive of obstructive jaundice. In a patient who has history of diarrhea with mucus, that is ulcerative colitis, obstructive jaundice going together, you are thinking of primary sclerosing cholangitis, which is what antibody? P-ANCA. Okay, P-ANCA antibody which is there. Okay, and remember that this is ulcerative colitis associated with primary sclerosing cholangitis, which has onion peel fibrosis. Sclerosing, a lot of fibrosis happening, and it gives the beaded appearance on MRCP, prune tree beaded appearance. Okay, right. Hereditary hyperbilirubinemia, which is conjugated. Doctors are conjugated. Dubin-Johnson rotors conjugated, right? The rest, that is Gilbert and Krigler-Najjar, this is unconjugated. Out of this, which is the most benign? Remember Gilbert, B for BE, this is benign, right? The patient will be normal only when there are periods of stress. There is going to be this jaundice which precipitates. Which is the one which has maximum kernicterus? Crigler-Najjar 1. Maximum kernicterus is Crigler-Najjar 1 because what do you have here? Completely absent UGT1A1. There is complete absence of this conjugating enzyme. So increased unconjugated bilirubin going to the brain causing kernicterus. Maximum is seen with that. Which one has a black liver? Which one has black liver? Remember, black liver is dark liver, D for Dubin-Johnson. Okay, that is Dubin-Johnson has black liver, dark liver. Okay, so this is hereditary hyperbilirubinemia. Okay. Going to the next one, the acid-base disorders. The most important that you need to know here first is the normal values of pH, bicarbonate and PCO2, right? All these values are normal of 4,4 containing 7.4, 24, 40. They are 4,4 containing. Bicarbonate starts with bi, 24, because you will get confused ki normal 24 kiska tha, bicarbonate ki PCO2. So remember, bicarbonate is 24 and PCO2 is 40. So, and the other mnemonic that you need to know here is Rome. Respiratory, opposite, metabolic, equal. That means in metabolic, all the three are either decreased or either increased. They go in the same direction, equal direction. So, whenever you get acid-base disorder ka question, first look at pH, less than 7.4, this is acidosis. Next, look at PCO2, increased, bicarbonate, increased, these are going in opposite. The pH change and the rest of the two are going in opposite. Respiratory opposite. This is respiratory acidosis. Respiratory acidosis, which is seen with hypoventilation or hyperventilation. Hypoventilation or hyperventilation. When does the PCO2 increase in the body? When there is hypoventilation. Example, opioids, right? Sedatives, opioids causing respiratory depression, hypoventilation, emphysema. Okay. Next one, again this is acidosis. PCO2 30 is less, bicarbonate is less. All the three are going in the same direction, equal direction. This is metabolic acidosis. Okay, metabolic acidosis. Remember, metabolic acidosis can be high anion gap or it can be normal anion gap, HAGMA and NAGMA. What are the causes of normal anion gap metabolic acidosis? NAGMA. Who is NAGMA? Remember, NAGMA is our Didi. NAGMA Didi. What does DD stands for? It is seen with diarrhea. Okay, NAGMA is seen with diarrhea. It could be GI diarrhea, it could be renal diarrhea, or it could be the diarrhea occurring via the fistula. Okay, like ureterosigmoidostomy or any other fistula. GI diarrhea or renal diarrhea. Renal diarrhea means renal tubular acidosis. Okay, renal tubular acidosis. Okay, and remember that which is the renal tubular acidosis, which has hyperkalemia, very, very important. More potassium, more in 4. Type 4 RTA has hyperkalemia. Okay, this type 4 RTA which has hyperkalemia. Okay, so this is normal anion gap metabolic acidosis, right? Going to next one, some important flashcards in medicine which are very, very important. The only serological marker present during the window period in hepatitis B infection, we have discussed hepatitis B serology in our short videos, right, in the app. Remember, anti-HBC. C is something which is constant. C for constant positive. Always positive in any stage of infection. Window ho, acute ho, chronic ho, carrier ho, kuch bhi ho. Anti-HBC is always positive. If anti-HBC is negative, then you are thinking of post-vaccine immunization status where there is anti-HBs positive. The only thing positive there is anti-HBs, right? Next one, rot spots are seen in infective endocarditis. Is it an immunologic phenomenon or a vascular phenomenon in infective endocarditis? Remember, in infective endocarditis, the immunologic phenomenon, what is the mnemonic for immunologic phenomenon? GORI. Glomerulonephritis, Osler's, rot spots, these are immunologic phenomenon. Janeways are vascular. Okay, Janeways are vascular. Okay? And in infective endocarditis, the vegetations which are there are big vegetations. They extend onto chordae tendineae. Okay, that is what is given in the question, extending to chordae tendineae. What criteria do we use for infective endocarditis? You have the Duke's criteria, modified Duke's criteria. Okay. Cannon A wave, that is very big A wave, which is occurring in complete heart block, when the atrium is contracting against a closed valve, right? No association between atrium and ventricle. So, complete heart block. On the other hand, where do you have absent A wave? When the atrium is not contracting, that is atrial fibrillation, right? Next one, hyperkalemia, type 4 RTA, more potassium in 4. Cancer causing polycythemia is renal cell carcinoma. Remember, from the kidney we get erythropoietin polycythemia. Which other tumor can cause this polycythemia? Which brain tumor? Remember, polycythemia blood related, hemangioblastoma. Cerebellar, like hemangioblastoma seen with VHL, 1-Hippel Lindau, that also shows polycythemia. Nodular glomerulosclerosis, which is KW lesion, Kimmelston-Wilson lesion is seen with diabetic nephropathy. KW, diabetic nephropathy. Remember, I've discussed the nephrotic syndromes. There's one more YouTube video after this that you should be watching for more extra 10 marks in your upcoming FMG exam or NEET PG exam also. The link of which has been given in the description of this video, and I'll put it in the comments also, which is the other medicine pathology video from Sure Shot that you should be watching. Okay. So, vasculitis, amyloidosis, nephrotic nephritic syndromes I've discussed there. Okay, please watch that. So, Pratiksha, that's what. Vasculitis has been discussed in that video. You can quickly watch that video. Okay, it's a very short video only. Pure red cell aplasia is associated with thymoma. Okay, pure red cell aplasia is thymoma, which is also associated with myasthenia gravis. And in which viral infection is there aplastic crisis? Aplastic crisis is seen in which viral infection? That is parvovirus. Okay, that is parvovirus. Next one, investigation of choice, initial investigation in DVT per se is duplex. Duplex means Doppler. Okay, what clinical sign is positive in DVT? The Homan sign. Okay, what sign is positive? Homan sign is positive. Bilateral upper limb pulseless disease is Takayasu. Remember, Takayasu affects the aorta and its branches, most common subclavian artery affected, leading to pulseless disease. Okay. Anion gap is not increased in renal tubular acidosis. Remember, Nagma Didi, renal tubular acidosis mein nahi badega. Whenever there is metabolic alkalosis, generally there is hypokalemia. Remember, alkalosis is all Kalosis, all K loss. It is generally associated with hypokalemia. You see this metabolic alkalosis in Cons, or do you see it in Addisons? Where do you see this metabolic alkalosis? Cons or Addisons? Remember, increased aldosterone. Aldosterone, ALAL, causes alkalosis. So, you see increased aldosterone in Cons. Increased aldosterone in Cons. So, remember, always remember, aldosterone increase causes alkalosis and hypokalemia. Okay? Right. Next one, in CHPS, because there is vomiting, acid going out, there is alkalosis, because in vomiting the acid goes out. There is hypochloremic, hypokalemic alkalosis that you see here. CHPS is a medical emergency or a surgical. It is medical emergency. Right, you give IV fluids and electrolytes, you do not do surgery directly. What surgery do we do here? Ramsted's pylorectomy. Okay, Ramsted's pylorectomy. What fluid do you give here? Do you give RL? No, you give normal saline. Remember, RL, ringer lactate, worsens the alkalosis, because the lactate in the ringer lactates basically gives bicarbonate in the body. So, that will cause alkalosis. So, you never give ringer lactate in alkalosis. Next one, granulomatous condition with hypercalcemia is sarcoidosis. Hallmark of sarcoidosis is bilateral hilar lymph nodes. Very, very important. What kind of granuloma it is? Non-caseating granuloma. It is non-caseating granuloma. Disease causing orchitis, parotitis is mumps. Okay, mumps causes orchitis and parotitis, right? Next one, Conn syndrome, hyperaldosteronism will cause hypokalemia and alkalosis. Okay, that will cause hypokalemia, alkalosis. It will cause alkalosis. Commonest cause of paroxysmal hypertension is what tumor? Pheochromocytoma, right? Sympathetic overstimulation. Very, very important, Hinault-Schönlein purpura is what deposition? IgA. Hinault-Schönlein purpura is now called as IgA vasculitis. What is the triad that you see in Hinault-Schönlein purpura? Remember, purpura is parpura. What is this parpura? It is palpable purpura, arthralgia, and pain, abdominal pain, GI bleed. Remember, this is palpable purpura. It is because of vasculitis. It is not because of thrombocytopenia. Very, very important here. The platelets are normal here. AR stands for arthralgia. P stands for pain, abdominal pain, GI bleed. Okay, abdominal pain, GI bleed. Okay, this is Hinault-Schönlein purpura. Very, very important. Spontaneous bleeding is seen in hemophilia. What kind of bleeding do you see here? Is it the cutaneous or mucus wala bleeding? No. It is the joint bleeding. Hemarthrosis. Okay, that is hemarthrosis. Medullary thyroid cancer is what is associated with MEN2. MEN is med. And remember, this is medullary thyroid cancer, which is coming from parafollicular C cells. It has this amyloid stroma which is present. Okay, presence of amyloid stroma. What amyloid? ACAL. Because what is the tumor marker here? Calcitonin. Parafollicular C cells secrete calcitonin. So, ACAL wala. Drug of choice in CML? Imatinib, which is tyrosine kinase inhibitor. In emphysema, you see respiratory acidosis. Why? Because the CO2 is increasing. Right? There is CO2 not going out. So, that is why there will be respiratory acidosis. Pneumatoceles is common in staphylococcal pneumonia. Okay, staphylococcal pneumonia. In celiac disease, you see anti-endomysial antibodies or also anti-TTG, tissue transglutaminase. So, celiac disease is malabsorption, right? The villus atrophy is there, associated with dermatitis herpetiformis, where you give dapsone. Okay, D for D, dapsone. Alpha-1 antitrypsin deficiency results in the chronic liver disease plus pan-acinar emphysema, plus it results in pan-acinar emphysema. For alpha-1 antitrypsin deficiency in the liver, they will give you PAS-positive condition, diastase resistant. PAS-positive, diastase resistant in the liver is alpha-1 antitrypsin deficiency. Wilson's disease, remember, is increased urinary copper. In the urine, the copper is increased, but the ceruloplasmin is low. Okay, the ceruloplasmin is low, the urinary copper is increased. The gene affected here is ATP7B. Remember, Wilson, beta, son is beta, ATP7B, chromosome 13, and this is autosomal recessive. Remember, chromosome 13 at the age of 13, puberty. Wilson attains puberty and Patau's Burkhardt2 with the eyes. That is, आँखों ही आँखों में इशारा हो गया. Wilson, Patau's Burkhardt2 eyes. So, Wilson, Patau, BRCA2, eyes मतलब retinoblastoma. Remember, all this comes at chromosome 13. Okay, all this comes at chromosome 13. We have learned the mnemonics for genes and chromosomes also, right? Drug of choice for trigeminal neuralgia is carbamazepine. Okay, carbamazepine. Next one, classical episodic flushing with diarrhea with wheezing. This is classical of what tumor here? Carcinoid. What happens in carcinoid? There is increased serotonin. There is increased 5-HIAA because seroto comes from tryptophan, which has indole group, 5-hydroxyindole. So, 5-HIAA increased. Classically, remember, it affects the right-sided valves, like the tricuspid regurgitation is what it can cause, because serotonin is utilizing all the tryptophan. So, remember, this can present with what vitamin deficiency? Niacin deficiency, because niacin also comes from tryptophan, right? Whenever you have this triad of cirrhosis, diabetes and skin pigmentation, right? Bronze diabetes. This is the hemochromatosis. Iron deposition, hemochromatosis, liver affected, pancreas affected, and the skin also affected. There is bronze diabetes, hemochromatosis. Remember, the gene is HFE gene, iron wala Fe gene. What is a chromosome? Chromosome 6. right? Remember, Iron Man has 6 abs, 6 packs. It is chromosome 6, autosomal recessive. In hemochromatosis, important. How are the hepcidin levels in hemochromatosis? Hepcidin is low. The low hepcidin increases the iron absorption. So, there's a lot of iron in the body. The low hepcidin is what you see here. Onion peel bile duct fibrosis, we said that's sclerosing cholangitis, primary sclerosing cholangitis. High levels of IGF-1, right? IGF-1, which is basically your mediator for growth hormone. This is suggestive of acromegaly. Okay, that is acromegaly. Water deprivation test. Water, which is a hormone in the body controlling water, diuresis, antidiuresis. It is antidiuretic wala. So, this is used for diabetes insipidus. In diabetes insipidus, there's a lot of polyuria with increased water in the urine, right? There's a lot of diuresis happening. So, how is the urine osmolality in diabetes insipidus? It's water, water, water in the urine. So, urine osmolality is low. Serum osmolality is high. Opposite happens when the ADH increases, like in SIADH. Okay, in SIADH, the opposite thing happens. Okay, and remember, SIADH is generally seen in trauma ka patient or a small cell carcinoma of the lung. You will see this SIADH commonly associated with that. Okay? Is this clear with everyone? Right? Clear? Quickly discussing this genetic disorders, very, very important. This is the double bubble sign seen with duodenal atresia, which is associated with Down syndrome, which will have this single palmar crease. Okay, Down syndrome, that is trisomy 21. Where you have this overlapping fingers, what disorder, genetic disorder is this? Remember, Edwards. Edwards, E is the 5 alphabet. It affects the 5 fingers and the toes. So, what does it cause in the toes? Rocker bottom feet. Okay, it causes rocker bottom feet. Remember, Edwards. In Edwards, very, very important in the triple marker. Everything decreases in the triple marker. ED, it causes early death. EE, it is trisomy 18. Okay, it is trisomy 18. When you have this in the center, this cutis aplasia. This image is showing cutis aplasia. Remember, P for P, this is seen with Pataus. Pataus has a lot of PPP, like there is cleft palate, there is holoprosencephaly, there is a polydactyly, there is polycystic kidney disease. A lot of that is seen with Pataus, trisomy 13. Short stature with webbing of the neck, this is seen with Turner's, 45XO, Turner's. In Turner's, remember, there are streak gonads, streak ovaries. So, the secondary sexual characters are absent. There is no breast development. And in Turner's, because the ovary is failed, the FSH is high. Whenever the gonads fail, the FSH increases. So, the high FSH-LH levels will be there. So, this is what kind of hypogonadism? Hypergonadotrophic hypogonadism. Hypergonadotrophic hypogonadism. Turner's is associated with coarctation of aorta, bicuspid aortic valve, horseshoe kidney. That is what it is associated with. The male counterpart of Turner's, that is Noonan syndrome, is associated with pulmonary stenosis. Okay, that is associated with pulmonary stenosis, right? Remember this. And remember, Turner's is the one basically where there is everything related to like lymphatic obstruction. So, lymphedema, cystic hygroma, all this is seen in Turner's. Okay, that is seen in Turner's. Clear with everyone? Interleukin cytokines may, remember interleukin 1, interleukin 6, TNF alpha, these are for acute inflammation. TGF beta, remember FB, this is what is responsible for fibrosis. That means this is for chronic inflammation, right? It is a anti-inflammatory. Right, it is causing fibrosis, anti-inflammatory. Okay, this is anti-inflammatory. Which other interleukin is anti-inflammatory? Remember, interleukin 10. Thus says bus. Bus karo inflammation, no more inflammation. Interleukin 10 is also anti-inflammatory. Interferon gamma is the one which leads to granuloma formation. Gamma is granuloma. It is stimulated by interleukin 12. Okay, interleukin 12 stimulates your interferon gamma. Okay, is this clear with everyone? Right, so this is interleukins and cytokines, amyloidosis in the other video we have discussed. So guys, we'll stop here for today, and I hope this has been very high yielding last minute revision. This is absolutely important. Please do share it with your friends as well who are going to appear for the upcoming exam. Right, we are expecting a lot of questions from the topics that we have discussed in the today's session. Right, these are like the must know points that we have discussed. No mistakes in the topics that we have discussed. Okay, all right. Thank you so much, everyone. When do I see you again? I see you again tomorrow morning, 11 a.m. With the MCQ marathon in-app live class. Right, the Speed Medsynapse app. There is in-app live class. The details of the app and the plan, subscriptions, all that is given in the description. You can check there. So all the subscribers can join in tomorrow for the MCQ, mixed bag MCQs, to learn the MCQ solving skills. How do you rule out options, all of that. We have part 8. Till now we have had 7 sessions. Part 8 will be there tomorrow. Okay? All right. That was about this one. Thank you so much, everyone. Thank you for all the love and all the very best FMG students for your upcoming exam day after tomorrow. Just maintain your calm, right? And you are going to do much better than you think. You know much more than you think you know. So have that faith, have that confidence, and go with that confidence for the exam. Okay? Thank you so much, everyone. Goodbye. Take care. Keep studying. Keep revising. Keep Medsynapse.